So the title of the rounds are Traumatic Cardiac Injury, the St. Mike's Experience. And, we've been a trauma hospital for many years. And over the years in the Echo Lab, we've come across lots of interesting echoes as a result of cardiac trauma. And I've kind of collected several over the years. So I'm just going to share that experience with you today. So these are the objectives. So we're going to review actually 4 cases of trauma patients, but at the end we'll have a general discussion. And these are 4 interesting but not necessarily unusual traumatic cardiac injuries. Okay, and as Dr. Chow mentioned, we're actually one of only a handful of hospitals outside the U.S. that's verified as a level 1 trauma center, and it's one of our core programs, and we take great pride in this. As Bob Howard, the former CEO, knows, it's been a really big focus of the hospital, and it's really a team effort, a big team effort. So we're going to start off with. We always start off with echoes, right? We'll start off with the first echo cases. So here's the first case. I'm going to ask one of the cardiology residents to. They're not hard. So there are no tricks to this. So I'll ask Chris to just tell us what he's seeing.
Yeah, you got to get close to the mic, or nobody can hear. Can you come up here, Chris? Good.
Paraceronal long and short axis view on the left and on the right. Overall, in terms of the actual function from the walls that we're seeing here on the long axis, looks like fairly preserved LV function. Looking around the heart for any effusions, don't see any effusion. The RV on this view looks maybe a little bit big compared to sort of the other chambers. And then otherwise, at least the mitral valve. Yeah, a little bit down too. And then we're seeing the mitral valve there and the aortic valve open.
Yeah, okay. So as Chris mentioned, Chris is one of our C2s. So, preserved LV systolic function, the right ventricle perhaps maybe a little bit dilated, and you want about some hypokinesis. Obviously, you want to see it on other views. And importantly, no pericardial effusion if you're talking about echoes in a patient with potential cardiac trauma. The one thing is that's a bit unusual here is that there's something funny about the septal motion. And if you remember, my last rounds was funky septal. Were you here for the funky septal motion rounds? No, you weren't. Okay, those were good rounds. There's something funny about the septal motion. It may be related to the cardiac trauma. I won't say there's anything classic about it, but there's something unusual about it. There's this little oscillation here. Okay. All right, so here's a short axis with color Doppler.
So it looks like there's some color flow from the LV into the RV.
Yeah. Yeah.
Worried about kind of VSD.
Yeah. Okay. So you worry about a ventricular septal defect. What part of the septum is this?
So this would be sort of the inferior.
Yeah. So this is the inferior portion of the septum. Okay. So here's the apical 4-chamber view. Yeah. So kind of actually this confirms what you thought about from the paraceronal long axis, right? The right ventricle is mildly dilated and it's hypokinetic as well. And you can see the flow from the left to the right across the ventricular septum. This is through the muscular septum, right? This is a muscular VSD, but this is not a congenital muscular VSD. This is an acquired muscular VSD. And here's subcostal view, really nice images, right? You can see we've interrogated in multiple views. So there's predominantly systolic flow. There's a little bit of diastolic flow. And you can see that on the CW spectral Doppler on the right. You can see it's predominantly systolic, high velocities as expected if it's a muscular VSD. And a lot of times they're not necessarily pan-systolic, depending on the dynamic nature of it. You might hear more of a systolic ejection type of murmur as it closes down, but this one looks like it's predominantly going to be pan-systolic, perhaps based on the size of the defect. Okay, perfect. So this is an acquired ventricular septal defect, inferior portion of the ventricular septum from some type of cardiac trauma. Okay.
They would say what kind of trauma.
Yeah. So here's the case. So this is a 67-year-old guy, prior bypass surgery, and he was working on his deck, and he inadvertently, I don't know how he can do this, fired a nail gun into his chest. Didn't lose consciousness, although he was seen by Bob Chisholm. And in Dr. Chisholm's note, he said he felt a little bit dizzy after. So Bob was wondering whether he had a bit of a vagal reaction to the steel gun. Anyways, he was okay, and then he drove himself to the hospital. And it was this wasn't St. Mike's, it was another hospital. And he was actually stable, taken to the OR, and the nail gun was removed and was discharged. And a few weeks after, he began to have shortness of breath. And then a murmur was discovered that he had a transthoracic echo, and then he was referred to Dr. Chisholm. So he saw Dr. Chisholm saw him as an outpatient for this. So okay, so here's the transesophageal echo. So I'll go through this a little bit. So you can see it's this is a transgastric view, slightly off axis. You can see the hole through the septum, and slightly off axis, short axis view. But you can see just like the transthoracic, it's a defect in the inferior portion of the muscular septum, and it's quite clean. It's we didn't have 3D at that time. Would have been interesting 3D. But it's you can see it's quite a large hole, and look,
He has no other injuries. Like people.
yeah, we don't have details of the operative report or the echo at that time. It's possibly had a pericardial effusion associated, but when he was taken, when this nail was removed, I'm not sure what exploration they did, etc. And it's possible that things got sort of sealed up. Anyway, so based on the defect and his symptoms, Dr. Chisholm decided to close it. So this is the closure procedure. So you can see transeptal puncture, and back in the day, I think this was 2009. Dr. Chisholm was the guy for structural heart interventions, right? Now it's all about Neil Pham and Samuel Nasser and Akshay Guy, but it was Dr. Chisholm back in the day, right? Okay. So you can see transeptal puncture on the left, crossing the defect on the right, and it's actually they just use a VSD closure device. So here is a post. You can see the closure device in the ventricular septum. It's well seated. There's a little bit of residual flow, at least immediately post procedure. It's very short, it's very brief. It's probably not pansystolic. And this is a transthoracic echo a few weeks after, so it's sealed up over time. Yeah. Okay. So that's the first case. Okay. Here's a chest X-ray of the next case. That's a young guy who came in with a gunshot wound. I don't know if any of you. This is one of these cases you might see once in a lifetime. So this is a chest X-ray of a gunshot. Any other residents want to tell us what they see?
Something right next to the apex.
Yeah. There's this opaque structure here in the PA, and you can see it here in the lateral here. Right. And that's the bullet. So this is the transthoracic echo. You want to take a crack at this, Michelle?
Yeah, sure. So parasol long axis, then we have the short right side.
Yep.
Follow nicely. Well, hard to comment on EF here. That maybe might be slightly down.
Yeah, maybe low normal. He's a young guy. We see typically it's not unusual to see low normal EFs in healthy young individuals.
RV looks okay.
Yep.
And on the short axis again, it's okay. No, there are no fusions.
Yeah, no pericardial effusion, kind of similar to what Chris was saying. So now here's short axis views.
muscle level, short axis view, again, no clear effusions, although all seem to be thickening okay.
Yeah,
And the same more where there's like this bright structure in the interoceptal area.
yeah. Yeah, you can see a bit of artifact from it. See a bit of positive artifact, a little bit of ring down artifact. Not much shadowing, interestingly. So you can see it here again. So I was the echocardiographer on call, and actually the cardiology resident who did the transthoracic echo, I can't remember what time of the night it was Stephanie Poon.
Oh.
So, okay, here's a CT scan. So you can see the bullet here with lots of artifact. Okay, so here's the story for this one. So all the stories are interesting, right? So this is an 18-year-old man. He was walking home late one night and he sustained a small caliber bullet wound to the right arm and right chest. And he was stable on arrival to the emerge. He had a right-sided pneumothorax and a chest tube was placed and drained 600 cc's of blood. So it's a bloody hemopneumothorax. And he had these investigations and they identified this bullet and he was taken to surgery. It was Mark Peterson actually was the surgeon on call who took him to the OR. He did a ventriculotomy, he incised down and he teased out the bullet from that was lodged in the left ventricle and he closed the ventriculotomy. And on inspection, what he thought was that the bullet likely entered through the right chest, through the right atrium. He found an entry site in the right atrium and then lodged, for whatever reason, it ended up lodging in the.
So through the tricuspid valve?
No, the valves were fine.
No, but maybe it was open. I mean, how do you get from the right atrium to the particular
I suspect.
LV, right? I mean,
Yeah, I suspected probably. That's a good question.
I mean, the heart could have gone through the tricuspid valve when it was open.
It's possible. It would have been interesting time.
And then lodges in the septum.
Yeah, and you'd have to pull out your CSI.
Timing, right?
Okay, he did well. All right. This is the pre-images. It's a little bit bright in here. Then we can cut the lights in the back. Sorry. The other one? Yeah, perfect. So pre on the top and then post on the bottom. So obviously ventricular function looks a little bit snappier post-operatively. It may have been a couple, day one post-op perhaps, but you don't see that. Obviously, you don't see the bullet anymore. It's just been removed. Okay. Okay. All right. Case 3. Maybe we'll ask one of the fellows to. And then this one was a T, in part because the transthoracic images were very, very poor. So, Mike, you want to?
This is a transgastric view. The left ventricle looks small, hydrodynamic. There's flattening of the septum, like a D-shaped septum. The right ventricle looks very large.
Yeah. So dilated RV, hyperdynamic small LV, flattened septum.
This is mid-esophageal focused view of the right ventricle. So again, the right ventricle looks severely dilated with moderately, at least, reduced systolic function. I'm wondering if there's a defect just below the interatrial septum, and there seems to be a bit of dropout there. So
Yeah, I think it's just dropout.
okay.
Yeah, but it didn't prove there was no color Doppler flow. So
Okay.
So here's just some last couple of shots, just 2 views of the right ventricle and the transgastric view.
Yeah. So at 90, kind of like more of like a long axis of the right ventricle, you again appreciate how dilated reduced systolic function is. And there's something kind of bouncing around the apex there.
Yeah, probably pap muscle.
That muscle, okay.
Actually, there wasn't significant tricuspid regurg, interestingly enough. Yeah. So what's the diagnosis here in this trauma patient? This is what we get asked a lot actually when we do echoes on trauma patients. To rule out this particular, because the troponin's been elevated.
like RV infarction, MI, or as a result of
Yeah, so what's
this-
traumatic injury causing elevated troponin and hypokinesis?
could be causing like a dissection of the coronary artery?
That could be true, yeah, but the more common one's like a contusion.
Contusion.
Yeah, is a classic term, so RV contusion. And as many of you know, the right ventricle sits anterior, it's right below the sternum, and that's the one that's going to be affected most often, at least for blunt chest trauma. So that's a lot of times we get asked to do echoes mainly for contusion and other things like the less common things like traumatic coronary dissection or but it certainly can't have been described. So this case was a 61-year-old man, and this was after a suicide attempt. He jumped from a second-story window. He'd had a history of metastatic carcinoma of the prostate, and he was depressed. And it was actually he had multiple suicide attempts before. He had multiple injuries: right-sided rib fractures, flailed chest, fractured pelvis, other fractures, liver laceration. And he had a thoracotomy and surgery, etc., to try and kind of repair the injuries as best as possible. Unfortunately, despite that, he had progressive decline, and the keel was withdrawn. Last case. I will ask. Hi, Priya. I'll ask Priya.
Okay.
You're Priya. This one's not hard.
Oh, Peristernal long. At first glance, there's no pericardial effusion. Wonder if the walls look a little thick.
Yeah.
With the LV.
Yeah.
Um,
At least concentric remodeling, right? The LV is small.
yeah. Function. I don't think it's normal. I think I would say low normal at least.
Yeah, it's tough. It's a little tangential. It's kind of, it might be going in and out of plane a little bit here.
And then the RV is not normal
Yeah.
from a function perspective. Sorry.
Yeah.
To clarify.
At least compared to the size of the LV, the RV looks dilated. In comparison, it may not measure dilated. And you do wonder about the systolic function, at least in relationship to the left ventricle. Okay.
So here we're RV inflow, looking at the tricuspid valve. The first thing that looks odd to me is I wonder that the leaflets don't seem to be coapting.
Yeah.
And I know tricuspid injury is a common trauma finding, so I'd be worried about if there's injury to the valve. The leaflets aren't coapting normally.
Yeah. Yeah.
You see a little bit of prolapse.
Yeah, actually, it looks like it's directed directly back into the right atrium. So this is a flail anterior leaflet of tricuspid valve, and you can see the coaptation gap. And as you mentioned, this is one of the classic valve injuries, or at least for blunt chest wall trauma, because like as I mentioned, the RV is sitting right anterior. You can actually get traumatic disruption of all valves, but the tricuspid valve is kind of the classic one.
So it also, I think it assumes that the trauma occurred in ventricular systole.
Yeah. Yes.
As opposed to diastole, where this probably wouldn't happen.
Yeah. No, that's the
Timing.
physiologics. It's when the valves are closed and then there's a sudden rise in intracardiac pressure, and then that leads to a disruption of the valve movements.
Neat. Okay.
So. And just to finish up here, you can see that there's severe tricuspid regurgitation, and triangular CW, super dense. So this was an 85-year-old woman, and she suffered her injuries she was in a pedestrian motor vehicular accident. So she was a pedestrian, unfortunately. Multiple injuries, and in the end, they tried to repair as much as possible, but she progressively declined, and she also passed away as well. Okay. All right. So just the last few, it's going to be a short rounds. Yeah, the last few minutes, just some words about cardiac trauma. We can have a discussion. There's a few other cases that probably could have put in. Talk about what the other classic cardiac traumas would be. So you can actually broadly classify cardiac trauma, at least in terms of etiology, to blunt and penetrating injuries. And I showed you two cases of penetrating injuries, two cases of blunt injury. with outcomes ranging from lethal injury to spontaneously resolving arrhythmias. And I think, when people think about cardiac trauma, they think about commotio cordis, right? It's the ones what's his name, Hamlin, the Buffalo Bills safety, who was thought to have, Dr. Chen, who thought to have a football helmet injury to his anterior chest to cause a cardiac arrest. A lot of patients don't make it to hospital if it's a significant cardiac injury and they die before arriving. And the survival rates to those who actually reach medical facilities ranges from 20 to 75%. It's part of our mandate as a level 1 trauma center is the management of trauma in general, particularly cardiac trauma. It involves a systematic approach, and it's the standard ATLS protocols. And part of that is, at least in our hospital, is cardiac and vascular surgery. I don't think it can be a level 1 trauma center without good cardiac and vascular surgery. So the mechanisms for blunt trauma is thought to be 3 potential mechanisms, but they can be a mixture of the 3, of course. The direct impact on the anterior chest. There's a sudden high-speed deceleration, and that's thought to be the main mechanism for one particular type of cardiac trauma, which I did not show you. And there's the compression of the chest as well. Motor vehicle accidents are one of the most common causes and could include all 3 of the mechanisms, but there are others. Falls from height, crush injuries. They're sports related. The other than the helmet injury is the classic is the baseball hitting you on the anterior chest. And there's a few other unusual ones, like being kicked by an animal, like a llama or a horse or a donkey or something. It's good to cause the blunt cardiac injury. So cardiac contusion following blunt chest trauma can result in myocardial necrosis, ultimately can even cause rupture and sudden cardiac death. And we've seen patients who have cardiac contusion with associated pericardial effusions as well. I didn't show you a case. We had one that was a very localized small anterior pericardial effusion related to blunt chest wall trauma. On top of the sudden decelerating force, leads to the compression on the anterior side, on the sternal side. So that's called the coup. And then the thoracic spine behind can contribute the additive traumatic force, and that's the contra coup. So it's the coup contra coup. And with that, the distance between the septum and spine decreases, and essentially the heart kind of is caught in the middle. Penetrating cardiac trauma is probably a little bit easier to understand. It's a direct injury. It's the most fatal type of chest trauma. Mortality rates ranging from 16 to 43%. You can have complications including bleeding, tamponade, cardiac failure, etc. And of course, prompt management is essential for these patients. And usually involves surgical drainage of pericardial effusion and the repair of the underlying cardiac injury. And that's the role of the cardiac surgeon. And then if it's related to vascular injury, then that's cardiovascular surgeon or vascular surgeon. And does anybody know the type of injury, the classic injury resulting from deceleration forces that I didn't show you? That I have one case, but yeah, so it's a traumatic aortic injury. And do you know where it's classically felt to be located based on attachments and of the aorta?
The aorta is fixed.
Yeah.
Descent?
Yeah, so it's at the
Ligament trace.
yeah. It's just the descending thoracic aorta, just kind of close to it.
Subclavian artery.
Pardon me?
Subclavian artery.
I think she's trying to say subclavian artery.
Yeah. No, that's that's where that's what we said. Yeah, agree. Okay, and the complication of cardiac trauma, I've showed you some of these: pericardial effusion, you get abnormal wall motion from the contusion, decreased ejection fraction, intramural thrombus, valve injuries. I showed you a tricuspid valve injury. I have a patient I'm following who had a traumatic aortic valve injury and had a repair of the ascending aorta, left with moderate regurgitation. You get conduction abnormalities, pseudoaneurysm, aneurysms, and septal defects. I've shown you We find that's probably the most common that we've seen in a few septal defects related to different types of penetrating injuries, knife wounds, for example, and nail guns. So I think this is my last slide, but my last slide actually is this X-ray, which was a different patient. This was a second nail gun injury. So that's the nail here.
Whoa.
Classic X-rays. So yeah,
Nail gun is dangerous.
yes, the nail guns. Don't play with nail guns. That's one of my take-home messages. Don't play with nail guns.
I guess the issue is that somebody pulled that out. Then,
That's what happened to the first guy.
so they pulled the nail out and left the hole and maybe didn't think about the fact there might be a hole.
Yeah, actually, this if I can show you this one was a bit more complicated. Yeah, a bit more injury. So, then we'll save it for another time. Okay, and I think that's it. Thank you.